Hello, and welcome to today's video commentary on thyroidectomy for the treatment of Graves' disease. I'm Kaniksha Desai, an endocrinologist from Stanford University School of Medicine, and will be your moderator. Joining me today are two esteemed thyroidologists, Dr. Tracy Tylee and Dr. Quan-Yang Duh. Dr. Tylee is an associate professor of medicine at the University of Washington in Seattle and serves as the program director in the Division of Endocrinology for their fellowship. Dr. Duh is joining us from the University of San Francisco, where he is the chief of endocrine surgery. Both are experts in the management of Graves' disease and use thyroidectomy for the treatment of Graves' disease. As some of you may know, thyroidectomy is the least used treatment option of Graves' disease. In today's session, we will explore the indications, techniques, and outcomes of thyroidectomy in the management of Graves' disease, and why you should consider it as a primary form of treatment for some of our Graves' patients. So I wanted to start off with our endocrinologist, Dr. Tylee. Dr. Tylee, can you briefly review Graves' disease in a sentence or two, and then focus on the common treatment options for Graves' disease, specifically for surgery as a treatment option?
Sure. So Graves' disease is one of the most common causes of hyperthyroidism in the United States due to antibodies that are targeted against the thyroid stimulating hormone receptor. These antibodies essentially turn on the thyroid and lead to uncontrolled thyroid hormone production. Now, the treatment options that we have for Graves' disease are targeted primarily at the level of the thyroid and preventing excess thyroid hormone. We don't currently have treatments targeting the underlying pathophysiology of Graves' disease, which would be targeting the antibodies. So in order to control the hyperthyroidism associated with Graves' disease, we can treat patients with either a medication. Methimazole is the most commonly used in the United States, which interferes with thyroid hormone production and decreases the amount of thyroid hormone that the thyroid can produce. Or we target the thyroid itself, destroying it through radioactive iodine or removing the thyroid through surgery. These all are valid options for controlling the hyperthyroidism associated with Graves' disease, but they each have different risks and benefits, which is what we often have to take into consideration when making recommendations to patients.
So how common is a thyroidectomy, and what circumstances would you recommend a thyroidectomy for primary treatment of Graves?
So as you mentioned earlier, it's really very uncommonly used for the treatment of Graves' disease. Historically, in the United States, radioactive iodine was most commonly used, but over the last 10 years, that shift has really moved towards the anti-thyroid medications. And that typically is our first-line therapy. The main reason for that is there's a small chance that patients with Graves' disease could go into remission, and there's a chance that they would be able to go off all medication over time. Unfortunately, if they're treated with radioactive iodine or surgery, they're going to be hypothyroid lifelong and require medication. So using one of those two options as our primary treatment is not very common. However, there are some patients where methimazole or the antithyroid medications just aren't effective. Either they have adverse reactions to the medications, they are not able to tolerate the medications, they're planning pregnancy in which the medications are not an ideal choice, or most of the cases where I've referred patients to surgery, we just have a very hard time controlling their thyroid hormone levels despite adequate doses of medication. And they just feel miserable. They've been hyperthyroid for months. We can't get things under control, and they just want to be done with it. And surgery is a great option for that because it's going to be the quickest way to control their hyperthyroidism. And then even though they'll be hypothyroid, we can work to get them on a stable dose of levothyroxine post-op.
So Dr. Duh, I know you just get the referrals for surgery, but is there an ideal patient that you get for surgery?
Well, the ideal patient usually don't need a thyroidectomy, and that's a problem. So, but the usual patients that I see that need a thyroidectomy have issues that are specifically related to things that are better treated surgically. So the most common one's eye disease. I think patients with eye disease in general do better with less disease progression in the eye disease with surgery, because you remove the gland, you remove all the antigens, and I think there's enough support that if patients have bad enough ophthalmopathy, that's what the best treatment is. I don't know about the newer medications, how that would affect the need for surgery, but that's probably one of the most common things. The other ones, Dr. Tylee just mentioned, issues with the medication. Either, I have seen patients with developing agranulocytosis, for example, but those things are pretty rare, or liver function abnormality that they're worrying about, or just don't like to take the medicine. And those that are very impatient, surgery obviously is the fastest thing to do. Another group that we see used to be more often than now are Graves' disease patients with nodules. I think we're better now in evaluating the nodules. In the old days, somebody with Graves with a nodule would just say, let's just take it out. It's much easier. But nowadays, we're able to evaluate the nodules, and obviously these are usually by definition cold nodules. But now, if there's some concern, you can use biopsy to alleviate those concerns. So I think that is not as common anymore. And the people want to get pregnant, and they want to get pregnant soon. They don't want to wait till the remission, etc. So we see young patients that are already thinking about doing in vitro fertilization and all that kind of stuff. It's just easier for them.
Thank you. So we talked about some patients who'd really benefit from the surgery, including patients with complications of methimazole, pregnant patients, and patients with thyroid eye disease, TED. Dr. Tylee, can you talk about what some of the risks and benefits of doing the total thyroidectomy, specifically for those groups and just in general, compared to radioactive iodine and antithyroid medications?
Yeah, and I think that's really the discussion that we have with patients. Because all of these treatment options work, the discussion of the risks and benefits and which ones of those are most acceptable to our patients is really the big part of the discussion. So the main risk, other than the surgical risks with surgery, is that the patients are 100% of the time going to be hypothyroid after the surgery. And they're essentially going to be treating their methimazole for levothyroxine. Now, levothyroxine is a very safe medication. We can use it during pregnancy. We are not going to see the side effects of gay granulocytosis or liver function abnormalities. And so it's considered a very safe medication to take. But patients are going to need to be on a medication lifelong, and that's something that they need to be okay with. There's a lot of information about thyroid disease out there, and many patients are worried about, I'm going to gain weight, I'm going to be tired, I don't want to have to deal with these issues. And that's an important consideration as well, though in all honesty, most patients with Graves' disease who then are subsequently treated are going to gain some amount of weight because of the shift in their metabolism. So when we compare it to the other treatment options, with methimazole and the antithyroid medications, there is that possibility of remission and the possibility of being without medication. There's only about a 30% chance of that. Whereas the risks of the medication is, again, you're on a lifelong medication. There's the negative side effects of that with the liver function abnormalities and the agranulocytosis. The radioactive iodine, those patients are also most likely going to be hypothyroid. So that's the same for both of those. But it also can take up to 6 months for your thyroid hormone levels to normalize. Whereas surgery, you're going to be euthyroid when you come out of the OR and you're started on your thyroid hormone replacement. So it's surgery is a quicker resolution. The medication that you're going to be on is going to have fewer side effects than the methimazole, but does carry with it the risk of surgical complications that we would see that you're not going to have with the other options. So someone who's a poor surgical risk it's really obviously not going to be a good option for them because we have two other options that are equally good at curing the hyperthyroidism and probably safer for those patients. But I would argue for many patients, surgery is a very good and valid option.
Speaking of those complications, Dr. Duh, can you talk a little bit about some of those complications that you see in your surgical patients? And, is it different for Graves' disease versus cancer patients versus goiter patients?
Yeah, so the usual three complications we talk about in thyroid operation are injury to the recurrent laryngeal nerves and other nerves, and the injury to parathyroid glands causing hypoparathyroidism, and then bleeding after the operation that require reoperation, neck hematoma. If we take it one at a time, the recurrent laryngeal nerve injury, the usual rate we will quote to the patient, it's about a 5% chance of at least temporary injury. And of those, in the best centers, would be about 1% chance of permanent rate. Now, keep in mind that if you're trying to do a total thyroidectomy and you injure the nerve on the first site, you will probably end up with a lobectomy or at best a subtotal thyroidectomy. The hypoparathyroidism rate is usually also quoted at 5% temporary, 1% permanent, but the real rate is at least double that. We know that the risk for the parathyroid with the Graves' disease gland the way it is, it tends to be higher for parathyroid problem. And actually between the two, hypoparathyroidism probably is a worse problem, which is underappreciated. If you end up with the unilateral vocal cord paralysis that's permanent and the voice is bad, you can get a vocal cord injection, augmentation, medialization at one shot, and your voice is, if not 100%, back to 90%. If you are permanently hypopara, that's a problem. That's a worse problem to take care of than anything else. And actually, usually the surgeons just give those patients to the endocrinologist to take care of. But that's, in fact, I emphasize that issue with my patients more than anything else because there is no good treatment for it. And the bleeding issue is also more common in the Graves' disease. My usual quote to the patient is about 1 in 100 to 1 in 200 patients that may require reoperation after the operation because they bleed into the neck. Graves' disease gland tend to be quite vascular, and so usually a blood loss in the Graves' disease patient's operation tend to be higher. So those are the usual three things we tell our patients. Another thing that's very obvious, but it seems to be an issue for a lot of patients nowadays, is scar in the neck. Now, surgeons tend to downplay that. Well, you have an operation, you have a scar, but a scar in the neck versus scar someplace else is a different issue. And that's why, especially in places like Asia, there's a good number of these operations are being done through remote access, making incisions outside of the neck, transaxillary, transbreast, even transoral, can take it out through the mouth. And, using the robot and doing all kinds of things. So there's a lot of effort to try to avoid the scar in the neck. And so for some people, that's actually a very important issue. And that would, get into the consideration of whether or not somebody wants an operation.
So speaking of some of those complications, would there be any benefit of making sure the patient is euthyroid before surgery or adding any sort of SSKI iodine from your perspective?
Yeah, so a couple of things. I mean, I usually tell my patients, even though we're going to treat the hyperthyroidism permanently with surgery, that we prefer them to be euthyroid. The anesthesia will be safer. And at least theoretically, the risk of thyroid storm would be lower. I do have to tell you, though, even though we talked about it all the time, I actually have not seen a single case of a thyroid storm perioperatively, but we always prepare for it. So I think, that's definitely, we would like to have the patient well prepared. In a pinch, I have colleagues that, let's say somebody who just cannot be controlled well or are allergic to the medical treatment, and we just have to get it done. And then beta blocker actually can be used to do that avoid. Now, the use of iodine as a preoperative preparation, it has a very interesting history. I mean, traditionally people use Lugol solution, which is a little bit less strong than SSKI, but they basically use the same way. And the idea is you load the patient up with iodine, and through the Wolff-Jacob effect, that they actually can lower their overall, make them less hyperthyroid. But more importantly, the interesting thing is that iodine seems to shrink the thyroid. It's well known that it makes things less vascular, and many good studies have shown less blood loss in the range of 20 or 30 cc's. Not a difference in terms of transfusion or anything like that, but it does make things less bloody. Interestingly enough, if you ask the audience in a national meeting of a bunch of surgeons, and probably half of the people raise their hand to say they use it, and the other half don't use it. And so the reason is that some surgeons actually rather have a soft, even though maybe friable and more bloody gland, which is easier to manipulate, rather than a very hard, firm, but less bloody thyroid. So it's almost a personal choice. So I don't make a big deal. I usually use it, and I usually order it. Historically, you tell the patient take it 10 days for 10 days before, but I usually do it at 7 days. And the reason is that in the old days when scheduling can be an issue, if something happened at 7 days, you get one more week to get the patient back on the schedule to get it done, because after that, then it's no good. So I do it for 7 days. But if my patient forget, to take it or whatever, I don't make a big deal out of it. It's just a little bit of different operation. So yeah, it's got a good story behind it. And actually, it's difficult to get Lugol solution nowadays. Many pharmacies don't have it. So
thank you. Dr. Tylee, from your perspective, do you, ideally you would use methimazole to get the patient euthyroid. Do you use iodine frequently?
So oftentimes in referring patients to surgeons, I defer or at least have conversations with the surgeon to prepare the patient for it, because honestly, you don't want to start the iodine until you know the patient is going to surgery. So they will have already had their consultation with the surgeon. I have several surgeons that I work very closely with, and I think that's an important part of it, is you want to make sure you're both on the same page. And so they'll let me know if they need me to prescribe the iodine, which I'm happy to do, although, as you mentioned, it's sometimes a little hard to track down, in which case we just use methimazole to get them euthyroid. If the patient's euthyroid, usually the surgeon's happy to go ahead with it. I have one surgeon who really likes iodine, another one who doesn't care as much. So it's very much what Dr. Duh said, that it seems to be independent. But I do always start all of my patients on methimazole if there's no contraindications. For many of them, they want to do that for a short course anyway, to see, a short course being a year, to see if they can go into remission before making a final decision. But yeah, the iodine is done in conjunction with the surgeon.
Let me just add one thing. Some surgeons, and recently I begin to do that a little bit too, is to start the patient on some oral calcium, and I don't use calcitriol, but the reason is that because these patients are at higher risk for postoperative hypocalcemia, and so even though for most of my standard thyroid operations, I just start some oral calcium afterwards and then stop them, for Graves patients, I tend to get them going a little bit earlier so they're used to taking some calcium, because many of them will need it, and it's good that they know where where they put their bottles of Tums and where the the prescription or whatever it is. So
there is one other surgical question I wanted to ask for you, Dr. Duh, because I get this question frequently from my patients. Can you do a subtotal so that you make the patient euthyroid without making hypothyroid? I always get this question, so I figured I'd put it out there.
So it's a great question. I can spend the next 2 hours talking about this. Some great stories on that. So historically, when Coker first did thyroid operation, he did total thyroidectomy. And of course, he found out that the patient became hypothyroid, and that was one of the reasons he got his Nobel Prize. So he switched to subtotal resection for all his patients, not just Graves', but because we didn't have enough know about thyroid hormone supplementation. Now, so for the longest time, historically, the treatment is a subtotal thyroidectomy. And the way most people have done it before is do a bilateral subtotal, leaving a small amount on each side, anywhere between 2 to 4 grams on each side. And then subsequent to that, a very famous surgeon, Dr. Dunhill, came out with the Dunhill procedure, which is one side a total lobectomy and the other side a subtotal. And leaving, usually the surgeon will be in the operating room and say, I'm leaving the size of my thumb there. And that's somewhere about 4 to 6 grams. And that's and I've done that. So I grew up in the days and that was a standard operation. Now, the good thing and bad thing about that is that, the bad thing is that a surgeon never can get it exactly right. So you either get it too little, so you still have some hyperthyroidism, or you get it too much and they still need to take some thyroid medication. The complication rate turns out to be about the same. Even though you think that you leave something behind, you can prevent more complications. The complication rate isn't that different. So I think, and that's the reason why we sort of come to the conclusion that everybody just get a total. But knowing that historical perspective tell you several things. One is when the surgeon is doing a thyroid operation for Graves' disease, he or she does not have to be as aggressive about making sure every last bit of thyroid comes out. Because whatever you leave behind is not going to be enough to cause patient hyperthyroidism. I make a little bit more effort when I'm doing somebody with eye disease, because then, your idea is I want to have as little antigen as possible behind. But if I'm doing it for hyperthyroidism, most surgeons doing even the so-called near total thyroidectomy are not going to leave that much anyway. And you can, hopefully, if you do the Dunhill procedure, you have a better chance of protecting some of the parathyroid. That's one of the reasons to do it. And so if the patient is interested in it and actually understand the whole story of this, historically, when I used to do it, I would say 80% of the time, we can actually hit it within a reasonable range. And the trouble is that the other 20%, you end up still not quite, but one can argue that that may be okay. And for people that do work to doing operation in resource-constrained area, where patients may actually have trouble getting thyroid hormone consistently, subtotal thyroidectomy is still being used. And so if the patient asks me that, I say, sure. I mean, that's what you do in some countries that don't get thyroid hormone, but you do take some of these risks in terms of either incomplete operation. In that case, you may still have to take some medication, but maybe not as much. Or, in fact, you do enough that you still have to take some thyroid hormone. So,
well, thank you. I wanted to transition over to kind of the postoperative management. So, Dr. Tylee, do you, I know Dr. Duh had said he recommended patients to take calcium. Do you recommend them to take calcium, and how do you dose their thyroid hormone postoperatively?
So usually when they come to me post-op, the surgeon has had them on calcium, and by the time they're seeing me, we're deciding whether or not they can stop it. And so all of my patients are started on calcium post-op. I hadn't been starting patients preoperatively on calcium, but now I may be doing that. If I'm sending someone for surgery for their Graves' disease, we may discuss making sure they're on enough calcium. And then coming post-op, they're usually started on levothyroxine as well. And again, working with our thyroid surgeons, we're pretty similar on the dosing. It's usually it's weight-based, usually about 1.6 micrograms per kilogram per day, give or take. If it's a really high dose, that makes me a little nervous. Elderly patient, someone who's at really high risk of complications for hyperthyroidism, we may purposely underdose. And by the time I see them in follow-up, it's usually about 4 to 6 weeks after surgery. We get their repeat labs and then adjust the dose from there. It usually takes, 3 to 6 months to get them on a stable dose. And for Graves' disease, once they're on a stable dose of levothyroxine, I can send them back to their primary care for long-term follow-up, because unlike thyroid cancer patients, there's not a lot of ongoing surveillance as long as they remain euthyroid. They are always welcome to come back and see me if they develop symptoms of Graves' disease again, because it's always possible, although unlikely.
One other question with that, do you check PTH levels post-operatively, and do you base any sort of calcium calcitriol regimen on the PTH? I know some surgeons do.
Yeah, that's a good question. I think many of us now get a PTH. The end of the case, maybe about 10 minutes, as short as 10 minutes, as long as being in the recovery room. So that would be a few hours after the operation. And looking at the PTH level to predict how likely somebody may be severely hypopara. And the usual way, sort of generalization to think about it is that if somebody's, with the PTH above 20 and there's enough half-life that that's sort of almost a steady state, those patients in general will be fine. If they need calcium at all, they won't even need it for that long. Anything above 10, they're going to be unlikely to need some real serious treatment. When they're below 10, in some institutions, they're automatically started on calcitriol. So that's the way sort of people distinguish these things. I can't get them in the recovery room, so I get it at the end of the operation, and I gauge my aggressiveness of calcium treatment on that. And my usual thing is I just give them calcium carbonate Tums, and usually about 1 gram twice a day will be the usual. Some people I give them 2 grams twice a day. People that have gastric operations or some other, trouble with on antacid and stuff, we may use calcium citrate for it. The trouble with the reason we use calcium carbonate perioperatively is that it works faster. So we give patient the Tums calcium and says, you take this twice a day. And if you get tingling and numbness, take extra. And you take as much extra as you want because it won't hurt you. But if you're taking a lot more, you should call me so we can send you to the lab. And that way you can prevent a lot of phone calls. You can prevent some emergency room visits, because the worst case for these patients is that they go to the emergency room and frequently the people in the ED don't understand these things, and then get everybody all upset. They hyperventilate, make things worse, and the next thing you know is IV calcium and all that stuff. They just have to take extra Tums. And I tell people to take as much as they can or they want. They won't hurt them, but they obviously should have it checked if they're taking a lot of calcium.
Do you ever get patients who get hypercalcemic, or Dr. Tylee, have you ever seen the opposite?
I've never seen anyone get hypercalcemic after thyroid surgery.
Not on oral.
They get tired. No, they can't take. They get tired of taking that stuff. Like by the time they come to see me, they've usually stopped it just because they can't remember to take 4 Tums a day. And if they have a low PTH post-op, I will check it when I see them on follow-up, because very often it's temporary, and by the time I see them, it's back to normal and we can get them off of it. But if they had normal PTH calcium after the OR. I don't repeat it when I see them.
And actually, I tell my patients after 4 or 5 days, they're allowed to either drop lower or just stop the calcium, because the nadir for calcium occurs between 2 and 3 days. So if they're 4 or 5 days and they don't have any symptoms, they're not taking any extra calcium, chances are they're not going to be the people that really need it. And then they can, and if taking calcium is a problem, they should just stop. It's perfectly fine.
So we talked a lot about like the short-term complications. What about long-term? What is quality of life in these patients? I'll start with you, Dr. Tylee.
So I think that for my patients that have had surgery for their Graves' disease, usually the quality of life before surgery is not good. And that's a big reason why we're thinking about surgery. I have mostly two or three categories of patients. One is the eye disease. The patients who have eye disease, cannot get radioactive iodine, are not happy with methimazole. Those patients, the eye disease is very often the main driver of their quality of life. And so, but for the other patients, the ones who are planning pregnancy, surgery and getting started on levothyroxine often takes a lot of the anxiety of the medications, taking methimazole during pregnancy, worrying about hyperthyroidism recurring during pregnancy. All of that makes it easier to manage, and people are happy on the levothyroxine for the most part. The ones who really struggle with methimazole, who have side effects, who can't get their levels controlled, who have to go up to 20, and then they become hypothyroid, so we have to drop to 5. They become hyperthyroid again, and we're doing this up and down. They really feel awful, and they're frustrated, and they just want to be done with it. And very often after surgery, they feel great because things are stable. The levothyroxine is easier to manage than the methimazole was. So, it's obviously not going to be for everyone. Not everyone is going to feel perfect after having thyroidectomy. They may struggle with their levothyroxine replacement, but I haven't had anyone whose quality of life is worse after surgery. So far, everyone has felt better. Like I said, often because they're not doing well going into it.
And I guess you agree.
I agree, but I do want to put in a little caveat. If the patient is planning for pregnancy and that is a reason why they have a thyroidectomy, one of the worst complications you can have is actually hypoparathyroidism, because now that pregnancy becomes complicated for different reasons, not the Graves, but now you got to manage the calcium and hypopara during pregnancy, and that can be a bit of a chore. And so in terms of making people's life better or worse, that one you can definitely make things worse. So, but the rest, they're usually happier. So,
yeah. And with the pregnancy, if they have very mild Graves' disease, oftentimes I'll just let them go and see if we can get them off medication altogether. Overall, the goal is to do as little as possible to disrupt a patient's life. So if they can become euthyroid without medication, great. If we can put them on levothyroxine and keep them stable, it's great. But for pregnancy, that is definitely a consideration. We don't want to make things worse. So in some cases, we just let them be and see how they do before we make any decisions.
I know you guys talked a lot about coordinating care. Can each of you guys just briefly talk about how your practice works with conjunction with the other? I know they'll be slightly different, right?
Yeah. So when I have a patient who wants surgery for their Graves' disease, I usually send a message directly to whichever surgeon I'm referring to within our system. It's easy for us because we're all in the same system, so I can just send a message in our EMR. We're lucky in that we have a number of very good thyroid surgeons within our institution. And I just let them know what we're thinking, why we're discussing surgery. And I know my surgeons as well. So I know that they also won't do surgery if it's not appropriate, which I very much appreciate. And I always tell that to the patient, like, this is not you signing up for surgery. This is you having a discussion with the surgeon about what surgery might look like. It may not be the right choice for you, but I really think it's in their best interest to hear about surgery from a surgeon rather to hear about surgery from me. And that's another thing I really appreciate about the surgeons that I work with is they're happy to see these patients, even if they ultimately end up not doing surgery, which is why I trust them, because they're going to say no in the appropriate situations.
Yeah, I would agree with that. And in fact, frequently when the patients show up and I will explain to them that the good endocrinologists are very liberal in sending the patient to surgeons. Good surgeons in general are very conservative in recommending surgery for the patients. And so that is a good combination. A bad combination will be a endocrinologist that are really afraid to send patients to the surgeons and the surgeons who operate on everything that walks in. So that would be the bad thing. Whereas the other way around, so because sometimes my patient says, well, why did my doctor send me to you if I don't need an operation? And so it's actually important that they know that. And the other thing is that, I think when you work with people that you also get a sense of how liberal somebody is to, I have people that refer patients to me within a month of diagnosis of Graves' disease because their sense is that this patient has a high probability, that will need surgery as an option. And so some of these patients I'll see and I say, okay, go back and do your thing. And then, see me 6 months later or whatever. And then once in a while, we have some people with terrible eye disease and everybody knows that they just have to get it done. So.
Okay, thank you so much. I, for my practice, have multiple surgeons as well. We use both endocrine surgery and head and neck surgery here at Stanford, and we have great relationships with our surgeons. And I agree, we're on the side of send more and do less surgery than send less and do more surgery. So I totally agree with that. For the future, what do you guys, both of you, see as an area of research or new development? I know we have some stuff with TED coming out for the eye disease, but is there any room for growth in this area?
I think there's always room for growth. We don't yet have treatments targeting the actual underlying cause of the Graves' disease. Like right now, we're either treating the eye disease or we're treating the thyroid disease. There's not a lot of treatments for both. But if we can target the underlying mechanism with the antibodies or the antibody signaling, so immunotherapy, I think will be an interesting future. It's always hard to know where that's going to fit into our treatment regimen, given how cheap methimazole is and how expensive these medications are likely to be. But patients are definitely interested in actually treating the disease rather than destroying their thyroid. That is something I hear very frequently from patients. It's like, my thyroid isn't the problem, it's the antibodies that are the problem. Why do you want to destroy my thyroid? And I think it's a reasonable approach. And so it'll be interesting to see where some of these immunotherapies, how they develop and where they fit in.
Thank you. And then Dr. Duh, from a surgical perspective, do you see any changes?
Yeah, so going back to thinking about Graves' disease, if you think about it, it's really weird from a surgeon standpoint. We take out malignant tumors, we take out benign tumors that over-secrete. This is the only one that we're not really treating the basis, the source of the disease process. We're taking out the end organ because we can't control it otherwise. So I'm looking forward to the days that we don't have to operate on Graves' disease patients. Surgically, I think the advances in surgery are basically in two fronts. One is things that are related to minimizing the external appearance and trauma that people feel of having incisions. All these new operations and etc. That you see people do, although we don't seem to do it as much in the U.S. for it. It's very common in especially Asia and some European countries of remote access operations. things like some of the percutaneous treatment is probably not going to go anywhere. The radio frequency is definitely not something that you would use for something like this. Technically, in the operating room, there are things that you can do, and we do them, and many people do these things to prevent complications. So, for example, nowadays in the U.S. and in Europe, nerve monitoring is a routine that you use these nerve monitoring devices to protect the nerve, number one, and also to predict whether the nerve is going to work. So you avoid the major complication of having bilateral nerve injury. And in fact, in addition, there are other nerves that some people don't usually think about, but with Graves' disease being a bigger gland usually, the chances of hurting the opera singer's nerve, the superior laryngeal nerve, is actually higher, and so it's important that that we use all these technology to help us not hurt the nerve. For the parathyroid, the newest thing is these autofluorescent devices. The parathyroid fluoresces at a particular wavelength about 7 or 8 times higher than the background of thyroid. So there's been plenty of studies that show that you can lower the risk of inadvertent parathyroid removal, etc., and at least lower the risk of temporary hypoparathyroidism. It's a little bit hard to prove a long permanent hypoparathyroidism because the rate, fortunately, is low enough that you can prove it statistically. But I think many of these things are becoming more commonly used and can protect the parathyroid well. So,
great, thank you. I just wanted to leave our listeners, if both of you guys could provide like 1 or 2 kind of summary points, or just for our listeners, what you would recommend if you were considering thyroidectomy for your Graves' patient.
Well, from my perspective, I think the most important thing is to offer it to patients. I think as endocrinologists, sometimes we're hesitant to recommend surgical treatment for conditions that we know we could treat with medication or radioactive iodine, which we're actually more comfortable with ordering than with surgery. But recognizing that from a patient perspective, surgery actually may be a very reasonable option. A lot of patients are concerned about radioactive iodine, and I think we downplay their concerns and we downplay the possible long-term risks that we just don't understand yet. And I think that it's a great option for people who are comfortable with that. We know it works really well, but we need to give patients the option of surgery, just making sure that they know it's there. Be realistic about the complications and the risks of the surgery, just like we are with every other treatment option that we have for Graves' disease. But I think it's our responsibility to make sure patients understand they have 3 options for treating their Graves' disease.
Yeah, I agree. I would agree with that. And for me, I tell patients that for the majority of patients with Graves' disease, surgery would not be the only or the absolutely the best option. Most of the time, there are other options. And my job is to make sure that they understand at least the surgical part of it, what's involved, and what are the risks. In general, the advantage is it's very quick. You get it done, and it's done with. But it comes with noticeable complications that one has to be dealing with. And another thing is, I'm sure you have patients ask you that too, that if you were me, what would you have done? And many times what I tell the patient is, well, I'm not you, because we all have very different values. You know, I don't care I have a scar in the neck. I mean, I already have my C-spine outward and also another scar, like what's the big deal? But for some people, that may be the most important thing. If I have a temporary nerve injury, that would be bad. On the other hand, that would not be the end of the day. But if I were a broadcaster or if I am an actor, that could ruin my career. And so each things that some people may think that taking thyroid hormone is the worst thing ever. And I'm sure you hear these patients that, say, just a pill. So the kind of value that the patient has, I think, is very, very important. And I think treatment for thyroid disease and treatment for Graves' disease is probably the epitome of when we talk about patient-centered and how you engage with the patients to make decisions about what is best for them. So,
well, thank you both for joining me today on this video commentary to talk about thyroidectomy for Graves' patients.
Thank you.
Thank you.